I'm Anna Versfeld. I am a medical anthropologist, South African, and I specialize in TB and vulnerable populations. I've done quite a lot of work on TB and people who use substances. And over the past few years, I've really developed an interest and a focus on gender in TB. And for the most part, that has been looking at women in TB. But my interest is broader, it's gender in TB in general. And then maybe just to say, I've done quite a lot of work with Stop TB Partnership. So a lot of what I will draw on today comes from that work. So just giving credit and recognition to them.
My name is Andrew Medina-Marino. I am a public health researcher. I dabble in the quantitative and the qualitative. So still have a split personality on which one I like better. So my main focus is on all things TB and specifically TB in men's health and HIV in men's health. I work for the Desmond Tutu Health Foundation, and I am an adjunct associate professor at University of Pennsylvania School of Medicine and at University of Cape Town School of Medicine.
So, Anna, would you like to share some greater insights, maybe in 2 or 3 minutes, in terms of why exactly we should be concerned about TB in women in slightly more detail?
Okay, well, I mean, I would say we need to be concerned about everything that makes people vulnerable to TB or that shapes their care access, care quality, their capacity to complete treatment, and also the impact of TB, the long-term impact of TB, which is something I think we're only starting to look at now. Like, what is the ramification of TB on your life in the long run? But certainly there are biomedical and genetic areas that we need to be concerned about, and often this is what's raised. So it's the things like women are more likely to have genital TB, and this is rarely diagnosed, or pregnant women with drug-resistant TB, we don't actually have good information on drug regimes for them. Or another example was a TB Reach project in India, implemented by Innovators of Health, that showed that pregnant women have very high rates of with TB had very high rates of anemia, and that was affecting their health. But we know that we've been very, very slow to figure it out, that there is a lot more to TB treatment than medicine and the provision of tablets, which people will magically take and get better. So there's everything else that happens when someone gets sick. Who makes decisions about whether they're allowed to access care at all? Who takes care of sick people? And what stigma do they face? What are the consequences of that stigma? What are the costs of their being ill, and are those costs catastrophic? Do they have income? Where does that income come from? And all of that is gendered. So if we're going to be able to provide comprehensive care, we need to be thinking about these things. We need to be generating supportive responses to all of these things. And we therefore need to understand how they are moving through the world and how gender is shaping all of this. So I think in these contexts of deep inequality, TB tends to further disenfranchise or further marginalize, and we need to attend to that within the TB response.
So, Andrew, would you like to add in terms of how we can have a clearer picture why this is also a concern in men?
One thing that comes up is we understand how patriarchal systems impact women's access to care. But in a lot of these countries, there's still been very little work done around men's health and specifically around men and TB. So even within societies that are highly patriarchal, you can't necessarily make the assumption that, oh, men are doing better, because we really don't know that. And I would probably assume that they're still not, because such systems aren't going to be healthy for either men or women. I do want to give a very clean example of the concern for men and TB outside of just the higher prevalence ratios and what's known already about poor treatment outcomes amongst men compared to women. There was a recent meta-analysis, I want to say it was in 2018, that looked at TB adherence interventions to improve adherence to treatment and better treatment outcomes. And of the approximate 129 papers that they reviewed for the meta-analysis, there were only about 17 that stratified the results by gender. So right there, you don't really know what's happening in terms of interventions to try and improve these kind of outcomes, and who are they working for, men, women, neither, both. And we looked at those specific 17 papers to look at, okay, well, perhaps some of these interventions are working better for men compared to women, and you can optimize some of these interventions to improve men's health outcomes and inherently decrease that gender gap in terms of treatment outcomes. And what we found was, amongst those 17 papers that did stratify by gender, none of them showed better outcomes for men compared to women. And in most of them, there was a specific improvement amongst women compared to the control in the study. And for men, there was no improvement even compared to the control. And so if you assume that, for the most part, when people think about interventions for health, if it doesn't take a gender lens, it's more likely to, probably have a better effect for men compared to women. These are actually specifically showing that when you take a specific non-gender lens to developing these kind of interventions, they're actually improving these outcomes amongst women, which is fantastic. But then when you think about implementing these interventions, it's actually exacerbating that gender difference in terms of outcomes. So for me, the idea of trying to be concerned about men's health and TB is not only looking at the numbers, but also potentially thinking about the biases in terms of how the global health community has typically come to understanding that because historically women have been at greater disadvantage, that maybe the bias when thinking about these kind of interventions actually focus on women without necessarily thinking you're doing that. But when you develop an intervention that should be gender neutral, it's actually having gender specific effects. And those effects seem to be constantly better amongst women compared to men. And while we want to certainly decrease these barriers for women, the concern about those gender barriers still remaining for men, like Anna said, we should be concerned about anything that has an impact, including gender. And in the context of these kind of interventions, at least the ones reviewed in this meta-analysis, they're definitely showing better outcomes for women, which means that a gender lens needs to be taken. And if there's a bias, it might be towards trying to improve having better outcomes for women, even when one is trying not to approach these things in a gender biased manner.
But how can social science help us to provide a more comprehensive understanding and approach to the impact of gender in TB?
I would say here that a lot of Andrew and my perspectives have been developed in conversation. So I would also say that a lot of what we come to has been developed over time in conversation. So certainly my knowledge on men is deeply infused by Andrew's work. So the role of social science. I said earlier, we have been phenomenally slow to wake up to the need to respond to the social dynamics of TB. There's like quintessential social disease, and yet there's been this boiled down biomedical approach that is really sustained in TB sort of remarkably. But in terms of what social sciences can provide, I think, Andrew, you spoke a little bit about the incidence and prevalence rates and prevalence studies across countries that have shown these gender differences. But what's really striking is how much those vary between countries. So they're almost 1-to-1 in some countries, and it's 1-to-4. Like Vietnam, it's 1-to-4. So 1 woman to 4 men, right? And I know in some areas in Pakistan, Afghanistan, in fact, there are more women. So there are social dynamics that are shaping incidence and prevalence. This is what is going on. So we have to understand what those dynamics are if we are going to make a difference to TB. In terms of women, what social sciences offered us, or in terms of understanding of women, there's sort of quite general perspectives we have. Well, women provide care in home and they have a greater burden of care. These quite broad perspectives that we come to internationally, this is disputed. Generally, it's argued that women are more affected by stigma, though in some places it's argued that men are more affected by stigma. So social science can provide us with these insights. But I think what's really, really important is that we recognize that those broad general insights are not taking us where we need to go. They're a starting point. But because gender is contextually shaped, we have got to understand local and regional dynamics. And that is what social science needs to start being used for, in a way that it isn't. With gender, we've kind of got to these broad arguments. Men have got more numbers, women are greater affected, in terms of the burden of care, but we haven't got to the nuance. And until we get to the nuance, we cannot design effective interventions. So I'd say that's really where we need to start moving towards.
Anna did mention a very biomedical approach that's typically been taken. And I usually say, people always discuss, especially around TB, if we have better drugs and faster diagnostics will cure everything. And it's that social component that is constantly missed. And as much as I appreciate the angles that social science bring to the table, I think there's also humanities also have something to bring to the table. It's not just always about science and clinical approaches. The humanities, the social sciences should be brought into this as much as the biomedical sciences typically have. Regarding social science, again, I'm going to only be able to speak from some of my experience and work in South Africa. Around stigma, we fully recognize that stigma has a heavy burden for many diseases, where I think one area stigma has really been brought to the forefront is HIV. But I think the global TB community sometimes is quite conservative, and that's why there is this not always a recognition of what are things outside of biomedical responses that need to be brought in here. And I think it's making it more into the global dialogue, but I think it needs to be pushed a little bit faster. All of that said, regarding stigma, there really isn't a lot known, and where I feel there have been papers, many papers usually aren't stratifying by gender. And those papers that do talk about stigma and gender typically say that women have more stigma, but, understanding, well, there's different types of stigma. There's internalized, there's experienced, there's anticipated. And some of the work that we're doing is starting to show that, yes, both men and women experience stigma, absolutely. But it's different types of stigmas, and the mechanisms in which they impact people's behaviors are very different. And if we didn't start looking at this with a gender lens, we wouldn't be able to tease some of this out. And so a perfect example, and this has not been published yet, but in terms of stigma, we're finding that women are more likely to be impacted by anticipated stigma. And so the outcome of that anticipated stigma is women start to isolate themselves so as to put up their own barrier before having that experienced stigma. Whereas men, they have a lot of internalized stigma, and they talk about a lot of internalized guilt and shame, but then they're actually experiencing more isolation from their families and communities than women. And so unless social science starts to break down exactly what types of stigma, what's the mechanism of the action of that stigma on their behaviors, if we don't answer those questions, we're not going to be able to ever fully develop proper interventions. And those are the kind of things that biomedical approaches do not take into consideration.
At the moment, with the Global Fund and the National Department of Health, and we're doing a new community rights and gender assessment for South Africa, and we're in early days. But so we're just in the sort of protocol approval stage. But one of the things we're looking at is understanding who is not accessing care and why, which is something we are not able to access that much. So what we're doing is we're accessing youth affected by TB, and they're accessing their networks. And through their networks, they will find people who are currently not accessing the public healthcare system, but might be accessing other care. And that kind of exploratory, open-ended, we don't know what's happening here, but if we don't figure it out, we will not succeed, question is a really, really important place for the social sciences. It's when we don't know what we don't know, and it allows us to go in and find that. So I just wanted to add that in.
On to the previous question also. So really quickly, and again, this is something that Anna and I discussed before, which is, at least in my reading of the literature, a lot of the work still focuses on individual level factors. And I don't think there has been in the TV service delivery the same level of investigation at structural or clinical levels as there has been at individual level. And so I think there's definitely an angle for the social science to take that starts to really look at what are the true structural issues that are resulting in these kind of poor outcomes for men compared to women, at least again, within the South African context. There has been very little, and typically where a structural or a clinical level comes in is more about pure service delivery, and again, not even looking at not stratifying by gender to understand what's going on. So I think there's something to be said for the poor investigations, or the very few investigations that have been done regarding structural or community level issues that impact individuals' behavior, specifically around gender. And there's very little of that kind of multi-level work being done right now.
What should we consider in terms of optimal care provision for gender diverse people? So
I would start off by saying we just don't know enough. We are not gathering the data. I know that India gathers information on its third gender. I'm not sure of any other country that does at the moment. I wouldn't say there are no other countries that do, but I don't think it's routine, just straight programmatic data gathering, I don't think is happening. So I think a lot of what we think about when we think about gender diverse people in TB is sort of transposed from HIV. We know that gender diverse people, particularly, for example, transgender women, have higher rates of HIV, therefore likely higher rates of TB. We sort of do this like we hop from one to the next to get to where we're going. I know there's been a little bit of work done in India, a little bit of work done in Pakistan. We looked at it in South Africa a little bit when we did the last community rights and gender assessment. So I would just start by saying, by qualifying and say that until we start gathering information, I don't think we can speak to this with that much authority. I don't think we know enough about the biomedical needs of gender diverse people, because that will also vary. But I do think, and we saw this very clearly in the South African community rights and gender assessment, where we looked at, we included just some focus groups, but with transgender women, that healthcare providers are completely not equipped to provide rights-based care for gender diverse individuals. So I will give some examples that are sort of horrifying, but we did a few days of observations in a couple of different facilities, and it's just in the Eastern Cape and the Western Cape, but we saw things in those few days like the genitals of somebody being grabbed by a healthcare worker who was just checking, are you telling the truth? So I think we are a very, very long way from simply providing rights-based TB care. And I don't think that necessarily differs to any other health condition. But it's a snapshot. We need to do far better, far better.
What needs to happen in order to translate what we already know into actionable and tangible outputs?
I think we need to take a step back. We know that gender matters in TB. I would say that that's not broadly known or truly believed throughout the TB response. So I would say a first thing that needs to happen is that everyone working in TB needs to, the word is sensitized, needs to be sensitized or needs to understand why gender matters. Because until everyone working in the TB response understands that, it's always going to be an add-on, and it's always going to be the quickest thing that is dropped when things get tight, when work gets tough. So I'd say that's the first thing. We need to actually have everyone in the TB response understanding when it matters, how it matters, and why, how we need to look at it, how to generate data, what we do with that data, how we generate a program in response to that data. So I would say that TB organizations and institutions need to become gender equitable themselves. That means, you know, equity in their employment practices, equity in their pay practices, equity, they need to be reporting and response mechanisms for processes, you know, for gender inequity. If we don't have gender equitable institutions and organizations, how are we going to implement gender equitable TB responses? So I think that's something that we really need to step back and think about. We need gender policies in place. We need funding to require that organizations are gender equitable before we try and then make the TB world as a separate world to the people implementing it gender equitable. I'm very uncomfortable with gender being something separate. We do a gender analysis, and then we paste the gender analysis onto the work that we do, because there's always a disconnect. So we need to have gender as a lens. We need a gender analysis to be a lens to everything that we do. Then I would say we need our monitoring and evaluation to include gender indicators across the board. And until that is a requirement, again, gender will fall off the table as soon as things get tough. And we've seen that happen in other areas. Yeah, so then all of that also needs funding. So we need funding institutions to take gender seriously.
With all that said, at a minimum, we need to stratify our data by gender to even start to see what's going on. And you would think it's a very low-hanging fruit of reporting many of these national TB indicators by gender, because they already have the TB indicators. And for the most part, they should already have gender, but they're not stratifying. And then you don't see those stark differences. So there was a wonderful editorial by Moreno either last year or the year the year before, that spoke about the need for just basically stratifying what we already know by gender, where those variables are collected. I think that is very easy. I definitely think we need to do more research. And now, sometimes I hate it when researchers say, oh, we need to do more research, because there should be enough out there already to actually action. But I think in the context of TB, there's not actually enough out there. You know, for something like HIV, there's definitely starting to be that kind of critical mass of information where, you know, sure, we could do more research, but at some point there's enough there to actually start developing actionable, tangible outcomes, interventions. For TB, I truly don't think we're there right now. I do agree with Anna that there needs to be a focus on gender equity within the organizations that are actually doing TB work, whether it be TB research or TB programs. I definitely think donors are on the hook for taking a better gender lens, and it not just being looking at the word gender as assuming women's health. And I don't think donors are there yet.
What do you think should be a key take-home message that you would like to share?
You know, I feel like there's been a lot of work done on men and masculinity. Jeremiah, I think you have done phenomenally excellent work, and I feel a lot of our work is based on the seminal work you've done. What I have not yet, and you know, a masculinity lens tends to lend itself to assuming that the onus is on men because of how they view masculinity, and you know, then it's inherently, well, what are men doing wrong? And I think in terms of larger social science approaches, we haven't yet taken a look or an assumption that, well, but masculinity is also a social construct. And so we haven't yet really started to ask, what are the social structures that impose on men these ideals of what a man is, and a man cannot show weakness. And so I feel like right now we blame men for a lot of their poor health outcomes without assuming that the global community and the health system are also on the hook for these issues. And this, I give complete credit to Anna in helping me, think through some of this. But the health system perpetuates gender norms and assumptions around masculinity and what a real man should look like. And so by constantly putting the onus on men and their supposed poor health behaviors, it relieves from the hook the health system to do anything about this. And if there's anything to be said about this, it's that this is not just a men's problem. And I feel like in general for women's health issues, people have started to recognize how the system, how the health system, how communities, how cultures impact on women's health behaviors and women's health outcomes. And we have not yet done that same analysis or lens for men, and we're still blaming men for their own poor health choices or health behaviors.
I agree with you on that one. Yeah, I do agree that we gender blind institutions don't just harm women. Gender blind institutions harm everyone. And I think with TB, we see what we're tuned to see, and we are not yet tuned to see how we are shaping gender dynamics within the TB response. I want to just pick up on Andrew, your comments about our not yet having moved past research into implementation. Because with the Wave 7 TB reach work, all the projects were required to take a women's empowerment approach. And I know there was some discomfort around that, because why is it women's empowerment? But I hope I've kind of set that up a little bit through this talk. But those organizations were forced into a place of innovation, because we haven't stepped into that place of what do we actually do to make this happen within the TB response. And those projects have closed, are closing now. So I want to give a little punt. We've got 2 documents coming out. The one is a document that draws on their lessons around training healthcare providers on gender responsive care. How do you train them on gender and gender responsive care? That should come out in the next few weeks. And the other one, we've put together a compendium of activities and indicators for women's empowerment within the TB response. We are not claiming that it is perfect, but what we have done is said across all, I think it was about 28 projects, these are the things that they did, and this is the way that they measured them. So we're not saying that they're perfect, but we're putting them on the table, because until we start having examples of what you can do, people swim. They sort of flounder, rather. They don't know where to start. And it's risky. That taking research and designing a program is risky, because we don't know what the outcomes are going to be. So I do think we need a more iterative response with gender. We need the research, we need the programming, we need the research, we need the programming. And until that is bog standard, we are not going to get to the programming that we need.
If you assume that based on the research that we already have, that we would be able to create good interventions, I think the argument that I gave before about all of these interventions that have been developed in this meta-analysis, or all of these interventions that were analyzed as part of this meta-analysis, that of those that were even stratified by sex or gender, that none of them had better outcomes for men compared to women. So if you're assuming a reliance on what's currently known, and those are the interventions that came out, well then, none of them decreased that gender equity. And if anything, it enlarged them by ensuring that women had better outcomes, which is absolutely necessary, but it left men stagnant. And so this is where I would argue a lot more research does need to occur, especially around gender and around specifically men's health and TB, if we're focusing just on TB right now, because if those are the outcomes, we're in trouble. If those are the interventions that are being implemented, we're in trouble.
I'm going to make one point.
Absolutely, yes, please.
It feeds in. We need to start thinking about gender as a human rights issue. as a rights-based issue. We need to stop thinking in terms of binaries, like we're going to do this for men, men use more alcohol, therefore we're going to have alcohol interventions for men. We need to, which, yes, the data shows that more men use more, men use substances more men use substances, but we need to stop thinking about that. We need to start thinking in terms of what is it that people need to get into treatment, to be less vulnerable, to get into treatments and to get through their treatment. And there will be gender slants to that. But we need to be so careful not to boil these things down to men do this, women do that, thinking in terms of these binaries. I have seen that when we do that, we kind of take a step backwards. You get the simplified approach that reinforces gender norms or gender inequality. And Andrew, some of what you're talking to might relate to that, is that we haven't quite got to the sophistication of response yet in terms of gender.
But wonderful insights from both of you. Thank you so much.